Swayam Prabha. Digital India. Educated India.
So, in today's class, we'll go ahead with a chronic obstructive lung diseases. In previous class, we spoke about emphysema, in today's class, we'll talk about chronic bronchitis. Chronic bronchitis. These two together, we call it as COPD, chronic obstructive pulmonary diseases, right? Before I actually start with chronic bronchitis, if you can recollect the difference between emphysema and chronic bronchitis, you can see the diagram in the picture. Chronic bronchitis purely involves the tracheobronchial tree, right? It is the disease of the tracheobronchial tree. And emphysema, it is purely diseases of the respiratory bronchiole and alveolar on it. Okay, these two differences all of you should remember. So we spoke about emphysema and we'll talk about chronic bronchitis, which predominantly involves the tracheobronchial tree, right? So what is the definition? When you say the patient is having chronic bronchitis, in general terminology, anywhere itis means inflammation. Itis usually means inflammation. Where the inflammation is present, it is present in the bronchi, maybe major bronchi or minor bronchi, in any branch of the tracheobronchial tree. How is it? It is a chronic infection. Chronic infection or inflammation limited to the bronchial tree, we call it as chronic bronchitis. So, in general, before we go for chronic bronchitis, any inflammation of the bronchial tree, we call it as bronchitis. It is again divided depending on the duration of symptoms as acute bronchitis and chronic bronchitis. Acute bronchitis, all of you had some kind of an experience of acute bronchitis when you have viral infections or bacterial infections. It will be in acute nature. That means bronchitis develops in a short duration of time, and when you take proper antibiotic or precautions, it will resolve completely. That is called acute bronchitis. Most common causes are viral and bacterial infections. If the inflammation persists for longer duration, then we call it as chronic bronchitis. By definition, all of you can see, when you say chronic bronchitis, it is a persistent production of cough. Persistent productive cough for at least 3 months in a year for 2 consecutive years. The patient should have continuous cough and productive cough for 3 months in a year. Again, next year, you should have the similar kind of a cough. So if you have 2 consecutive years of cough lasting for 3 months, you can label those patients as chronic bronchitis patients, right? Most important thing is without any identifiable cause. Without any identifiable cause. So all of you should remember this definition when to say chronic bronchitis. Okay. After seeing the definition of chronic bronchitis, let's see what exactly causes chronic bronchitis. All of you might have seen patients who are especially in the near the railway stations or bus stations. They will be smoking cigarettes and they will be coughing. They will spit the sputum there only. So that means these patients are nothing but all those patients are chronic bronchitis patients. So what are the etiological factors? The most common etiological factor is heavy cigarette smoking. Heavy chronic cigarette smoking is one of the most common cause of chronic bronchitis. Then Persons who are living in smog-laden cities, dusty cities, where you have lot of air pollution, they will be inhaling lot of toxic gases or polluted air, ultimately causing chronic inflammation of the bronchi. Any metropolitan cities, they can cause chronic bronchitis. And if you inhale lot of vehicle exhaust, usually seen in congested cities, those patients will also have the more chance of developing chronic bronchitis. Then person who are working in industry, any industry which they inhale toxic gases, toxic or irritant gases continuously. Toxic or irritant gases continuously. So those individuals, they have more prone to develop chronic bronchitis. Why it is important? Chronic bronchitis. If the patient develops chronic bronchitis, it is usually irreversible. One, it is irreversible. What can happen? It can, in severe cases, it can develop into severe chronic obstructive pulmonary disease, going for severe, long duration, severe disease. Then ultimately, patient may have respiratory failure. When you have a respiratory failure, ultimately leading to right heart failure. In the later stage, patient may present to the clinical OPD as a right heart failure. Right-sided heart failure, because of primary pathology in the lung, we call it as cor pulmonale. Cor pulmonale. All of you should remember this, right? Then what all can happen? When you inhale these irritant gases continuously, especially in smokes, what will happen? The normal respiratory epithelium, which is pseudostratified ciliated columnar epithelium, because of constant irritation, the cilia will get destroyed and the respiratory epithelium will be transformed to squamous epithelium, multi-layered squamous epithelium. This is called as squamous metaplasia. Squamous metaplasia. If you take out the inciting agent at this level, it can reverse back. Condition can reverse back. If the irritation or the person working in these industries or person continues to smoke after this, what can happen? Metaplasia will turn into dysplasia. Even in many times, dysplasia can be reversible. Even again, if it continues the same thing, ultimately dysplasia will turn up into invasive malignancy. Invasive malignancy, lung carcinomas. So which type of lung carcinoma is most common in chronic bronchitis patients? Because of squamous metaplasia, dysplasia and invasive malignancy, the most common malignant lung tumor in these individuals will be squamous cell carcinoma. Squamous cell carcinoma. The most common lung malignancy in non-smokers is adenocarcinoma, right? So all of you know the importance of and complications of COPD. Next, let's see the pathogenesis. What all can happen? I just explained. I'll just repeat the same thing again. Pathogenesis. What all can happen when you have a chronic bronchitis? For example, we'll take in a heavy cigarette smoker. When you inhale cigarette which contains a lot of toxic gases, what can happen? First thing is the respiratory epithelium. What causes? There is ciliary damage, right? Cilia are very fine structures on the respiratory epithelium. Cilia will get damaged. When cilia get damaged, the normal mucociliary defense mechanisms will be lost. What can happen? The mucus starts accumulating on the surface of the tracheobronchial tree. Mucus starts accumulating in the tracheobronchial tree. When mucus starts accumulating, along with lot of dust particles which are stuck to these mucus particles, what can happen? It elicits secondary inflammatory changes. Secondary inflammatory changes to remove the dust particles or any microorganisms or the stagnant mucus. More and more inflammatory cells will recruit at this place. Ultimately, it causes damage to the respiratory epithelium and also the tracheal wall. So once the tracheal wall is damaged, again there is more respiratory epithelial damage, and because the continuous respiratory epithelial damage, more and more mucus starts collecting in the tracheobronchial tree. And one thing we should remember, whenever there is a mucus in the tracheobronchial tree, if it is collected, it acts as a very good media for secondary bacterial infections. Hence, these patients, they are more prone for secondary bacterial infections. Recurrent infections are more common in chronic bronchitis patients. Secondary infection. When you have secondary infection, what happens? Again, inflammation. Again, respiratory damage. So this forms a vicious cycle. Vicious cycle. So all chronic bronchitis patients, they have infection. Again, host immune response will get activated. We'll have a lot of inflammatory cells. Again, it will damage the normal respiratory epithelium. So it forms a continuous vicious cycle. Okay, one thing. Second thing, what can happen, as I told you in my previous slide, whenever there is a constant irritation, there will be metaplastic changes. Metaplasia. What metaplasia? Respiratory epithelium will turn into squamous metaplasia. Why squamous metaplasia? Why not other metaplasias? Squamous metaplasia. Because the main function of squamous epithelium is for protection. When you have constant irritation because of cigarette smoking or gases, so this respiratory epithelium, which is fragile, will turns into a protective epithelium. We call it as squamous metaplasia. So when you have squamous metaplasia, we have dysplasia, later on malignancy, that is squamous cell carcinoma. Okay, this is in the later stages. Then one more important thing all of you should remember, when you have a recurrent infection or when you have a recurrent stimulation by the irritant gases, what can happen? Respiratory epithelium, they have goblet cells in between, right? This is the goblet cell. When you have the main function of goblet cells is to produce mucus. You have submucosal glands also. The main function is to produce mucus so that this mucus protects the respiratory epithelium. When you have a constant irritation or stimulation, the goblet cells will undergo metaplastic changes. So respiratory epithelium which are there, they will turn into more number of goblet cells as a protective mechanism. This we call it as goblet cell metaplasia. Goblet cell metaplasia. Respiratory epithelium, normally you see occasional goblet cells. In chronic bronchitis individuals, you see many number of goblet cells lining the respiratory epithelium. That I will show you the histopathology when I take up in the next few slides. Then for production, along with goblet cells, you need to have more and more mucus production. These submucosal secreting glands also, they go hyperplastic changes. Hyperplasia of submucosal glands. And you will see a lot of chronic inflammation here, more of inflammatory cells. Whenever you have inflammation, what will happen to the blood vessels? Blood vessels will become congested. Congested blood vessels. Whenever the congestion there in the blood vessels, there will be edema in the surrounding places. There will be edema. So this is what you see. So these are what changes what I mentioned you. These are the similar findings when you see under microscopy if you take sections from any patient who is suffering from chronic bronchitis, right? This is the pathogenesis. Let's see. You can see the picture which is shown there in the PowerPoint. what exactly happens in chronic bronchitis. Okay, on right side you are seeing a normal bronchus. If you see normal bronchus will have a bronchial cartilage here, bronchial submucosal smooth muscle cells, and you have a respiratory epithelium and occasional goblet cells. This is the normal lumen. Normal lumen. In any patients of chronic bronchitis, what can happen? Because of continuous inflammation of the wall, submucosal wall, there will be edema, right? One thing, there is edema, recruitment of more of chronic inflammatory cells in the submucosa, chronic inflammation, vascular congestion, submucosal gland hyperplasia, submucosal gland hyperplasia, right? Along with that, increased production of mucin. Increase mucin production. Where will be the mucin? Mucin, whichever secretes, it forms a layer in the tracheobronchial tree. Along with that, surface epithelium will be damaged, or they show squamous metaplasia or goblet cell hyperplasia. One, goblet cell hyperplasia, squamous metaplasia. All these changes which occurs in the wall ultimately causes thickening in the bronchial wall. When there is thickening in the bronchial wall, there will be narrowing of the bronchial lumen. Okay, when there is narrowing, this more and more mucus starts accumulating in the lumen. That means the actual luminal diameter will be narrowed. You can see the picture how it is there in that, and the lumen is filled up with mucus. And this is very dangerous. When the mucus is present in a bigger tracheobronchial tree, it is fine. You still have some kind of a space for entry. But the same mucus, if it is present in minor tracheobronchial tree, it can totally occlude the lumen. Hence, whenever there is a total luminal occlusion in the minor tracheobronchial tree, we call it as bronchiolitis obliterans. Bronchiolitis obliterans. What all can happen? When there is mucus collection occluding the total lumen in the respiratory bronchiole or terminal bronchioles, there is an inflammation leading into fibrosis, chronic recurrent infection in chronic bronchitis ultimately leads to fibrosis. This fibrosis completely occludes or obliterates the minor tracheobronchial trees. Okay, this entity we call it as bronchiolitis obliterans. One more complications of chronic bronchitis is when there is a partial obstruction during the process. What will happen? The effective air entry will be narrowed because of narrowing of the lumen. Narrowing of the lumen. This is the mucus, and here we have the alveolar sac. So when there is narrowing of the lumen, air will enter into the alveolar sac. And what happens? While expiring, air will get retained in the alveolar sac. Ultimately, in the end stage, these patients will also present with emphysematous changes. Emphysema. Later stage, they may also have emphysematous changes. So this is one of the complications of chronic bronchitis, right? What all the patient, the clinical signs and symptoms of chronic bronchitis is mainly due to the copious amount of mucus production and obliteration of the small airways. These are the two main important complications that you see in chronic bronchitis, right? So how the patient presents with? That means the clinical feature of chronic bronchitis. All of you can see whenever there is an infection, inflammation in the bronchi, the first thing that you should remember is the patient will come with recurrent cough. What kind of a cough? Whenever you have a copious amount of mucus production in any patient with a cough, that means tracheobronchial tree is involved predominantly than the alveoli, because mainly mucus secretion occurs in the tracheobronchial tree. So these chronic bronchitis patients we present with cough with copious amount of mucus secretion. mucus secretion. If you can recollect, in my previous slide, I also told that these patients are more prone to develop recurrent infections. You might have a foul smelling sputum also because of continuous infection. These patients may have foul smelling sputum specimen. Because of complication of bronchiolitis obliterans and narrowing of the tracheobronchial tree, these patients will have dyspnea, difficulty in breathing. When there is difficulty in breathing, the respiratory rate will increase. So these patients will have tachypnea. Then increased heart rate, tachycardia. Especially in these kind of cases, okay, when there is total narrowing, air entry is totally diminished to the alveoli, there will be improper diffusion of gases. Hence, in severe cases, these patients also present with hypoxemia, hypercapnia, then ultimately leading to respiratory acidosis. In severe cases, what all can happen? The respiratory failure, ultimately leading to right heart failure, which we call it as cor pulmonale. So these all can happen in these patients, right? When there is severe hypoxemia, hypercapnia, how the patient presents? He usually presents with central cyanosis. We have cyanosis, especially in the mucous membrane. We call it as central cyanosis. Now, all of you understood how this patient present to the medical OPD. So, let's see, if a chest radiograph is taken in this patient, what are the important radiological features that we are going to see? If you can recollect my previous class of COPD, which contains both emphysema and bronchi, most of the patients, they will not present to the clinical OPD as a purely emphysematous case or a purely chronic bronchitis case. It will not. Usually the patient will have mixture of these two symptoms. Some patient will have predominant emphysematous features with minor component of chronic bronchitis. Some patient will have predominant bronchitis with minor component of emphysema. In general, if any patient comes with a chronic bronchitis, what all you can see? I told you, if you can recollect the pathogenesis, there will be bronchial inflammation and mucus plugs. So hence, in chest X-ray, if you taken, you will see prominent bronchovascular markings. Prominent bronchovascular markings. You can see in the picture, left upper picture is showing the lung. You will see prominent bronchovascular markings that have been extending outwards from the hilus. Right? All lines, gray white lines, what you are seeing, this is prominent bronchi and bronchioles. Why they are prominent? Mainly because of thickening in the bronchial wall, mucosa, because of continuous inflammation. Right? You have a one more chest X-ray picture just to compare. So that is the normal chest X-ray, how it looks, lung fields look, and this is a patient of chronic bronchitis. Hence, because of this appearance, they call it as dirty lungs. Dirty lung appearance in case of chronic bronchitis. And down picture, you have a CT picture showing, you can see those arrow marks. All those arrow marks, they are directing towards a prominent bronchi and bronchioles in the respiratory parenchyma. This is what you see. If it is complicated with emphysema, the adjacent lung parenchyma, they show emphysematous changes. Right? These are the simple salient features. How does these patients? Two important terminologies you should remember. In my previous emphysema class, I told you that you have emphysema patient, they present with as a pink puffers. And why they are pink puffers? They chest become bloated. They use pursed lips for expiration, and because they have increased respiratory rate and good oxygen content, the facial veins, all those veins starts engorged. So they look more pink. Pink means that there is normal oxygen concentration. When compared to those things, the first picture is pink puffers. Second picture, if you can see, they have facial swelling and there is cyanosis, bluish discoloration. So this is called blue bloaters. Why there are blue bloaters? There is blue bloaters are seen in chronic bronchitis patients. Chronic bronchitis patient. Why they are blue bloaters? They are bloaters because of edema. Okay, edema and puffiness because of heart failure, retention of the fluid. They are blue because of cyanosis. Why there is cyanosis? If you can, all of you know that there will be drastic narrowing of the tracheobronchial tree, which impairs the normal oxygen saturation. Right? All of you can see the picture. Once any patient walks to the clinical OPD, if he is puffy face with cyanosis, think of chronic bronchitis. With cough and sputum expectoration, that means from the distance we can say that this patient has more predominant chronic bronchitis symptoms. Okay. So this is the table. All of you can see. This is the table to differentiate between the emphysema and chronic bronchitis. What are those important points? Chronic bronchitis, usually these patients present at the 4th decade or 5th decade. Most commonly these patients, they are heavy smokers. But pure or predominant emphysema, they usually present 1 decade later. And they are more severe, they present in early stages. Right? When compared to cough, you tell me, cough with copious amount of sputum production is common in emphysema or bronchitis? It is more commonly seen in bronchitis because the mucus production is mainly occurs in tracheobronchial tree and that usually seen in chronic bronchitis patient. Emphysema patient, they will have cough but very minimal cough or very minimal sputum production. Right? Infections are more common in chronic bronchitis than emphysema. Emphysema also you will get infection, but recurrent infection, more frequent infections are more common in chronic bronchitis patient. Respiratory insufficiency, they are common, the more severe in chronic bronchitis and less in emphysema. And cor pulmonale, again it is more common in case of chronic bronchitis. Emphysema, it occurs as a late sequelae. So what happens to elastic recoility of the lung? Elastic recoility of the lung. In chronic bronchitis, because it involves mainly the bronchial tree, tracheobronchial tree, elastic recoility of the lung will be retained, will be normal or retained. But in emphysema, the elastic recoility of the lung will be lost. Why? Because this disease or this condition affects mainly the alveoli. Right? Chest radiography, yes, it is very important parameter to differentiate whether the patient is having purely chronic bronchitis symptoms or emphysematous features. So that I already mentioned you when I showed you the radiological pictures. And by clinical appearance, what you can say, pink puffers are nothing but common patients which are commonly seen in emphysema patient. Blue bloaters, they are commonly seen in chronic bronchitis patients. Right? Let's see. Before I go to the microscopic slide, I'll just show you the schematic diagram. What all you can see, what all actually happens when you examine the microscopic section of any patient who is suffering from chronic bronchitis. This is the schematic diagram. If you understand this, the rest will be easy when you see the microscopic slides. All of you can see the surface, you have a respiratory epithelium with cilia. Okay, there are goblet cells. You have submucosal glands. Right? What all can happen? 1. On the surface, loss of cilia. You have goblet cell hyperplasia. Goblet cell hyperplasia on the surface epithelium. That means you will see many goblet cells lying next to each other. Okay? Goblet cell hyperplasia. Then what all can happen? Because of constant irritation, you may see squamous epithelium, multi-layered epithelium, squamous epithelium. It is called as squamous metaplasia. Squamous metaplasia. This is you see in surface epithelium, goblet cell hyperplasia, squamous metaplasia. And you will see thickening of the basement membrane. Basement membrane thickening. Then comes the submucosa. This is whole thing, we call it as submucosa. What all can happen in submucosa? You will see a lot of edema. One thing. You will see many chronic inflammatory cells. You will see hyperplasia of the submucosal glands. They are usually seen occasionally, but here you will see groups and groups of submucosal glands. So submucosal gland hyperplasia. Vessels will be congested. Okay. These are the important schematic diagrams that have been shown in that picture. Okay. But after understanding this, let's see the microscopy, what exactly it looks. So all of you can see the microscopic picture there. I think it's better to understand. You can understand. See, one thing I forgot to mention, when there is goblet cell hyperplasia, we'll see a lot of mucus production. The thick mucus layer will be present on the surface. So the histopathology picture, what you can see, the surface epithelium on top, how you are seeing like this. This is under scanner view. This is the respiratory epithelium, lining epithelium. This is the luminal part. When you see the submucosa, you will see clusters of glands. You will see many clusters of glands. This is one of the important features of submucosal gland hyperplasia that you are seeing. The schematic diagram has been shown there. Whenever a lot of hyperplasia, the surface epithelium will show a lot of mucus production. Right? And see this picture. All of you can see on one side, the respiratory epithelium is clearly made out. That is stratified squamous epithelium. The same bronchial mucosa on other side showing many clear cells, goblet cells. This is how you see when you see the goblet cell metaplasia. And the downward picture, what you're seeing, that is hyperplasia of the submucosal glands. Right? All those things you should observe when you are seeing a microscopic slide of chronic bronchitis patients. Right? One more important index that has been mentioned in all the textbook, which is helpful in case of diagnosis of chronic bronchitis, is Reed index. Reed index. What is this Reed index? Before I talk about the lines, I'll just show you this picture. So this is the exact picture showing Reed index. What exactly this Reed index? So when you take a section from the bronchial wall, right? One proper section from the bronchial wall, think that this is a proper section, and here you have a respiratory epithelium. Right? We have a respiratory epithelium here. Okay. This is the line. And here submucosa showing a lot of submucosal glands. And here we have cartilage. That is bronchial cartilage. This is cartilage. Lot of glands, submucosal glands, hyperplasia. What you should do, how to calculate Reed index is, see the distance between the respiratory lining epithelium till the bronchial cartilage. Okay? If you think that this is AB, 2 points. 1 point near the base of the respiratory epithelium, 1 point near the upper surface of the bronchial cartilage. See the distance, which is AB. Then second distance, see the upper part of the submucosal glands from where they are there. This is till the upper surface of the bronchial cartilage. This will become C and D. And you have to take a ratio, CD. By AB, this distance divided by this distance is the Reed index. Right? So, normally the Reed index is 0.4. This by this is halfway, 0.2. So, any increase in Reed index, that indirectly shows that there is hyperplasia of the submucosal glands. Okay, this is how the Reed index is calculated. Okay, and see this picture, what all can happen. As I mentioned earlier, one of the most complication and dangerous thing in case of chronic bronchitis is the obliteration, a complete obliteration, and the obstruction of the lumen with the thick mucus, especially in the smaller bronchioles. Sometimes what you can see, if the patient coughs, if you can sometimes by bronchoscopy, if you can take out the mucus of phlegm, how it looks? It is a thick mucus. All of you can see. It is just takes the picture or shape of a tracheobronchial tree. It is just a mucus. The patient, when you take out all this mucus, the patient will feel better. Okay, this is just a thick mucus which is taking up the tracheobronchial tree. If you don't take up this, these mucus are the more prone for secondary bacterial infection, ultimately causing obliteration of the minor bronchi and bronchioles. See, bronchioles. First commonly involved are bronchioles. That's why when the bronchioles are involved, ultimately they get obliterated. We call it as bronchiolitis obliterans. We call the word called as bronchiolitis obliterans. This all of you should remember. Okay. So in today's class, we spoke about chronic bronchitis. So now we completed the COPD. The rest, bronchiectasis and asthma, will take up in our next class. I repeat, chronic bronchitis, when you should label chronic bronchitis, whenever patient comes with recurrent cough for continuously for 3 months and for 2 consecutive years, you call or you can label it as chronic bronchitis, without any obvious identifiable causes. The most common etiological factors that are seen is heavy smokers, smog-laden persons who are living in the highly populated metropolitan cities, then persons who are working in industrial setup where they have a lot of toxic gas exposure. All those features will come. So these patients, chronic bronchitis, it is inflammation of chronic in nature. Patient usually presents with recurrent cough and lot of sputum productions. That you should remember. And this is called as blue bloaters. On chest X-ray, these patients, they have prominent bronchial markings. That is called dirty lung. Okay. And cyanosis is more common in chronic bronchitis patient. These patients, they call it as blue bloaters. When compared to emphysematous patient, they are called as pink puffers. Okay. Most common complications is recurrent infections, respiratory failure, decreased oxygen saturation, ultimately leading to respiratory acidosis, respiratory failure, and right heart failure. So we call it as cor pulmonale, right? So all of you should go back and read chronic bronchitis and COPD in total today itself. Thank you.